Welcome to Billing Another Provider webinar. The goal for this one is to look at the different providers that can be billed and when you'll bill them. My name is Tom Ryan. I'm with Provider Outreach Education. I'll be your presenter. Today I'm joined by Aline Ziegler from my team, and she's going to help with the chat, answering questions or anything like that. What we're really going to look at is the denials and the information that's causing that. But the denials that we're going to focus on are when another provider should be billed or when you should be billing someone other than Medicare. And we'll talk more about that in just a little while. But I do have to go through some housekeeping to get started. So the first thing with the housekeeping is that the information from this webinar is available right now for you to download, and that information is the PowerPoint. It's available on our training center in the live events section. I'll have a link, put a link to that in the chat. Now, why did we on this slide give you the training center in general? Well, first of all, because it does allow you to register and have all of those different things that you might need. Second, we're going to put under live events, again, the presentation right now. But if you don't get it by the end of the day today, maybe tomorrow morning, we're going to take it down. Then we're going to put it up again with our encore presentation. Typically, that takes a couple of days, a couple of weeks to get out there, but it'll be up there for 60 to 90 days, and you can download it at any given time during that. We also then have a player on our website. So we take you to the training center for that purpose. I will let you know that during this event, I will stop multiple times to take questions. These questions will be addressed through the chat feature. So if you put them in chat, it's going to be easier for Alina and I to get them through to you. She may be able to answer them back and may not need to ask them live. So it's always best. Just go ahead, put those right into the chat as you think of them, and then we'll get an answer back to you. One final thought. After this event, I'm going to offer you guys the opportunity to take a survey. I know we do this after each event, but it's important after each event. A couple of things it does. One, it gauges us overall as a MAC, but two, it gauges the individual event. What did I do well? What didn't I do well? Did you like my PowerPoint? All of those types of things. Sometimes you'll hear me refer to this as the good, the bad, and the ugly. So another thing it really does, it gathers the topics you want. So if you want a certain topic or you'd like us to educate on something, you need to tell us so that we know. That's done through the survey. So again, the survey is going to be given to you at the end. We'll give you all the different ways to do that later. A couple of things we do want to remind you. First, this material is to assist the provider community. It is current as of the time that we gave it. However, Medicare rules do change, so you will want to view the CMS website just for that current information. We will give you answers based on the information that's given during the questions. I do have some pre-submitted stuff that I will go through. During that time, again, you'll hear me say questions or you'll hear me ask for additional information put into the chat should the person want more information. Some of the questions were really good and super specific, other ones were not. So I'll do the best I can. If you are recording, we do ask that you stop. CMS does prohibit the recording for profit-making purposes because we don't know how you're doing that or what you're going to use that recording for. We ask that you don't record us at all. On the other hand, as I said, I'm going to record this. While I record it, I will then post it to our encore presentation. So you'll have the opportunity to listen to it again, check it out, or do what you want to do, maybe refer a friend to it. Okay. Moving right along, I want you to be aware that I'm going to use a couple of CPT codes during this course. We do not own the rights to the CPT code. They are owned by the AMA. By continuing to stay on this webinar, you agree to the terms as set forth in the AMA copyright agreement. If you disagree, you may now disconnect. The copyright agreement is being displayed for you. What are we going to cover today? Well, my goal is to help you determine when another provider must be billed versus Medicare. In other words, why would you want to bill someone other than Medicare for a Medicare patient's services? Let's talk about that a little bit. First thing we need to do is kind of introduce the concept. What is the bundling concept? Why does it apply in terms of billing another provider? I'm going to explain who to bill when. Now, this will not be an in-depth discussion. There's many more criteria that go with it. However, this is kind of the starting point for a lot of those building points, and we'll talk about some of those different courses that we're offering eventually. Last, I'm going to provide you with some resources to help you in the future. Now, I will tell you, I don't do the resources all at the end. Sometimes I'll stop and go through based on the questions that you're asking and the information that I've been asked to give you. So keep in mind, resources may or may not be at the end. They will be provided to you on the slide deck at the end. I may cover them before I actually get to them. And again, it's all going to be based on the questions that you guys ask me. Keep in mind, pre-submitted questions were submitted and will be answered as the time goes through. I'll try to work them into the presentation. Other questions will be answered as time permits. Bundling. The first section explains the concept Medicare uses to indicate another provider is responsible for payment. The provider or their representative, whoever's billing us, has to determine who to bill before simply billing to Medicare. If you don't determine who to bill first, this is actually a form of abuse. You're creating Medicare costs that doesn't need to be there. That's why the concept is important, and it's important to understand, okay? So what is this concept, this bundling concept? Well, first of all, it's one payment for all provided services. Other providers then bill one provider. This provider then sends a claim to Medicare for all services covered. There are always, or not always, there are some times when exceptions are provided, and that is when we get the most confusing portion of this, which causes the most denials and other issues to go on. Also, not understanding how people bill, in other words, how a facility bills versus a doctor or versus a lab versus an ambulance, that can cause these denials. So the concept itself is when one provider is responsible for paying all other providers and responsible for billing Medicare for all services. That's the main concept that we need to talk about. Why? My favorite comment given for this one was that they did this to make the Medicare complex, the complex Medicare program even more complex. Well, that's really not the goal, but if that's how you feel, I just want you to be aware that we do understand that this does make things more complex, and we do understand and we get where you're coming from. Hopefully that's what we're here to help you with. So the goal, though, is to allow the provider to be aware of all services. The provider is where they are typically inpatient at, or the provider that is controlling certain things, such as home health and hospice. Even though they may be outpatient and providing those services, they have control over, they have to write a plan of care, they have a variety of other things. So the goal is, if you are the provider who's responsible for those, you want to know what's going on with that patient. That's part of what this bundling concept does. The next part is to reduce patient liability. So what Medicare is saying is, if they have this done and this done, it's really supposed to be billed through this organization, therefore it'd be one assigned liability. Part A or Part B liability, one deductible applied, one of everything, instead of what was happening previously before these concepts were put in place, where a facility could bill for something and then another person could bill for it, and then a supplier could bill for a different portion. And so they'd get deductible applied to each one, then they'd get co-insurance or co-pays applied to each one. So it really created a lot more patient liability. So the goal of the bundling process, the goal of all the different terms that we use for that same process, is to reduce the patient liability and the Medicare liability. Looking at the trust fund, it's ways to save money, ways to help make sure that we are not making a duplicate payment. We're paying the services to the right provider, for the right patient, for the right data service. And then that provider, the one that is controlling that inpatient care, that type of care, whether it's home health or hospice, etc., that provider is then responsible for paying all other providers. Again, it reduces that patient liability. Some of the payment systems actually give an all-inclusive rate or give one rate, a per diem rate. And so that makes it better for Medicare than having individual services billed. So it does have a variety of factors that go with it, and that was the goals. The goal really was patient control and patient care, and then patient liability and Medicare liability. The next slide is actually built directly from the question that was asked, and the person asked, they were familiar with SNF Consolidated Billing, but what else falls into this? Okay, so yes, that's going to be our second one. We'll talk about that in a moment. But the first one you need to be aware of is something called hospital bundling. And this is under the inpatient perspective payment system, or the cost-based reimbursement methodology. Now, the inpatient perspective payment system, or IPPS, is for acute care hospitals or long-term care hospitals. They have their own perspective payment systems. So a variety of hospital payment systems. But the goal with that one is, once the patient is inpatient, all facility services must be billed to that facility, and they must be responsible for them. Now, I did say facility services because, like doctor's visits or some of the professional services, don't fall within that category. because it's a facility payment, not a professional payment. So that's one thing to keep in mind of when we talk about some of these different bundling type services is it a facility or a professional payment? Okay. Skilled nursing facility consolidated billing. This is the one that was mentioned in the question, so the person is very much aware of it. But consolidated billing talks about services under the SNF prospective payment system, skilled nursing facility prospective payment system. Now, as part of their conditions of payment, conditions of participation, the SNF is responsible for paying other providers for certain services. Now, it is very similar to inpatient, except inpatient, it's almost all services. And this can include up to 1 to 3 days before the actual inpatient admission for some diagnostic and or for some diagnostic type services. SNF, on the other hand, it's done by procedure codes. What could the SNF be expected to do and what could they not be expected to do? And then we look at, hey, where is it being performed at? Is it in a hospital? Is it in a variety of different things? So once it's billed on a SNF claim under the prospective payment system, we have to provide a variety of different factors within this one. We will talk more about that. This one, though, it is called SNF Consolidated Billing. It's also a form of bundling. It's just the specific name is Consolidated Billing. Hospice. There is inpatient hospice. This is the basics of hospice bundling. So services related to hospice condition get billed to the hospice. Now, if they're inpatient, then we also have to follow the inpatient rules too, because there are certain things that are expected that this patient will be having. So it is why it's separated from outpatient. You will see hospice listed again under outpatient. Under outpatient hospice, it's based on the diagnosis alone. So is it related to the hospice care? If it's not, then it's billed to Medicare. So bundling anything related, anything not related, not billed to the hospice. We'll talk more about that in just a little while. Home health, it's the same kind of concept, but there's a home health plan of care. So there are certain portions of home services that are done under this home health plan of care, and the patient then chooses a specific provider to provide those services and a person to manage that. That's all part of the home health plan of care. Underneath that, then, if any of those services are done and they are part of that home health plan of care, then the bundling concept does apply. The last one is demonstrations. Now, this to me is the most interesting one. One thing that I always find interesting when we talk about demonstrations is that each one is unique and it has certain project bundling or not bundling at all. And it's very hard to say exactly what that demonstration project's going to contain. Why? Usually CMS has some goal. They're trying to look at a payment methodology. They're trying to look at a specific item. They're trying to determine whether or not this is better or more cost effective, whether or not this occurs this way. So each demonstration is unique in and of themselves, which is why we give them their own bundling category. Now, some of you may say, I've never heard of a demonstration, and that's simply because your area has never been selected to be with on. Others of you may say, oh yeah, I remember that one, or oh, we've had 2 or 5 or 100 of those. And it really is dependent upon where CMS selects them. Demonstrations can be across an entire jurisdiction, across the entire Medicare program, or they can be very specific to one city, one state, one certain area. So demonstrations are the ones that we don't talk about a lot because each one is unique and very different, very different. So let's see what we have for our first set of questions. Now, I already went through a couple, but I just want to remind everyone a couple of different things. When we talk about, the question is, when we talk about inpatient bundling, are these billed? How are these billed? Well, inpatient bundling is always going to be billed on a UB04 or an 837I institutional transaction, and you do follow your basic requirements. Now, if you're asking me how do you bill the institution, the hospital, the skilled nursing facility, whatever, that you'll have to ask them. They may need certain pieces of information to complete their claim that may not be on your typical type of bill. So for instance, a CMS 1500 claim form or 837P does not have all of the same information as the other types of bill that I just mentioned, which is the UB04 or the 837I. So help me understand what you meant by that so that I get that concept of what's being billed. I'm going to do the best I can with what I have, but again, I do want to offer you guys the opportunity to kind of ask some more questions on that if you have any more. Second question, Can you explain the hospital, or I'm sorry, can you explain the hospital and SNF bundling rules? I'm going to go into those next. I'm going to hold that question and we will get to that, okay? On the other hand, I would like to see if Aline has any questions in chat that we can answer now.
Hi, Tom. Thanks so much. We've gotten a couple questions. First off, Sally asked, how does ASC fit into this topic?
The ambulatory surgery center, Sally, please correct me if I'm wrong, and that's not what you're talking about. ASC is an ambulatory surgery center in most cases. That's the common acronym used. And how does it fit into this topic? It fits into the topic in that if a patient has elected certain things and still comes to an ASC, some of your services may have to be billed back to those other facilities. You're not different because you're an ASC. Now, a good example of that, at least in my mind, is when it's a skilled nursing facility and they're inpatient in a skilled nursing facility. They may be on a leave for a period of time, maybe 6-8 hours, and then they schedule things, or their daughter schedules things, their son schedules things, someone schedules, and they come into the ambulatory surgery center and you actually do a procedure. So some of the professional services might be billable to Medicare, but actually the regarding of the other portion might not. So when we look at the professional services, we do still have to check that. Now the ASC concept of bundling is a little bit different, and yes, some of the professional services will bundle into the ambulatory service code rates, etc. So ASC is another form of a bundling concept, ambulatory surgery center, and it just depends. So we can talk a little bit more about that later if we need to. Any other questions?
Thanks, Tom. She did put a follow-up, and it just says, regarding her question, are there professional services provided by a physician that may be considered bundled into ASC payments? And unless you have more to add, I think you already answered that.
Yeah, no, so the basic principle is no, and the ASC is an ambulatory surgery center. The physician's professional services are billed separately from the ASC. Now, keep in mind, if something were to happen during that day or during that time frame, and they go to a different physician's office, maybe to have a test or something done, not really a test, that's not a good one, but an X-ray would be a good one. And so they leave the ASC, they're running over, having that done. They just want to make sure something before that surgery gets met. Some of those services could have split billing, which could be affecting the ASC. We'll get more into that though. So. Any other things before I move on?
Yeah, Ashley asked, does ESRD fall into place for outpatient?
So end-stage renal disease, and if you're talking about a facility, yes, it would fall into it. So end-stage renal disease facilities could fall into outpatient. I'm not really sure what you mean fall into place for outpatient from that. So if a little bit more help would be needed there. Anything else?
One more. This one says, we provided dialysis treatment to a patient in our outpatient clinic on Part A in the morning. The patient elected hospice late that evening for related diagnosis. Would we bill the hospice for our treatment that occurred earlier in the morning?
Oh, no, that's a very good question. And we're going to get a little bit more into that, but the answer is no. The hospice cannot start bundling until the patient has elected hospice. Now, sometimes this is a battle within our system, and the battle is our system doesn't contain a 8 a.m. and a 4 p.m. code, just as an example. So they don't know that. So you have to do an appeal or other ways around that. That does happen too. You may have to put a condition code on it or other things too. So we'll talk more about that. But yeah, that's a great question. Anything else?
No more questions at this time.
All right. We'll start with one of the biggest concepts as we go through this explanation portion. Now, this is where I'm going to focus on certain types of bundling. The main type of bundling that people see a lot, and that actually causes us a lot of denials, is hospital bundling. Now, this is to bill the hospital, but it's bundling during inpatient care. Please keep in mind when we say inpatient care, I mentioned this earlier, but it can be 1 or 3 days before for certain diagnostic and other procedures. This means that they're related to or incorporated within that inpatient bill. So that means if they come in today, we're going to go back 3 days. If it's an acute care hospital, 1 day for certain other ones. And so that is a separate class that we teach on 1 day and 3 day billing. It gets a lot more complex and the billing is a little bit different, but the basic principle is that it does bundle in. Once a patient is inpatient and is admitted inpatient if for any reason they have outside services. The hospital is responsible for those services. The exception to that can be some professional services, such as a doctor coming in to do the inpatient evaluation. That doctor is not going to do that as part of a bundled care. Now, it doesn't mean that critical access hospitals couldn't bill method 2. It's not the same thing. It's a different type of billing and payment methodology. Okay, so that's not the portion of bundling that we're talking about here. And I did want to address that because someone did ask about critical access hospitals, but it's not the same thing. It's not what we're looking for. So what do you have to do and what's important to know? First, verify the patient status. Are they inpatient for this service or are they outpatient? Please remember, observation equals outpatient. Two different things. Observation equals outpatient. Check eligibility. Some patients could be inpatient, but they don't have Medicare Part A coverage, in which case this concept doesn't even apply because the hospital inpatient wouldn't be covered. The other thing to look for is, do they have on their eligibility screens, it's the Part A information, the Part A deductible information, they have days when the current billed span is available. So you want to make sure you're checking for that. If you're not familiar with that, check our portal user manual to see that. And we'll talk about that in just a moment. Also, please wait for the system to update. So if the patient tells you they're in a facility, you have to wait for the system to update. This leads to our first question that goes with that. Why is my money being taken back when I billed it and they were not in the hospital at the time? Well, be careful with at the time. They may have been in the hospital, only the Medicare system hasn't had that claim come in. What happens is, because the hospital bills in cycles, they bill for an entire stay in some cases. So if that stay is 10 days, then they're billing it, the earliest they can bill it is on the day after discharge. Now, keep in mind, what if that's a 30-day or a 60-day stay? Now we've got longer stays. There are times when they can bill in 30-day increments, but that's not always the case. Sometimes they literally have to bill for the entire stay. With that said, you provide a service. You being an external provider, whatever, you're not a facility. Do you know that you can bill that as you provide them anytime you want? So you bill it, provide it today, bill it tomorrow. Hospital comes back in 40 days and says, hey, they were inpatient during this time. The Medicare system automatically takes the money back, sets up the overpayment, does all of that, and sends you a letter. We don't actually have a person that stops, intervenes, and looks at that. It's an automated edit. It's done automatically. So the common working file is the communication hub that controls all of that. Communication hub comes back and says, set up an overpayment, set up a request refund, and that's what happens. So there's a variety of different things that happen with that, which I also think works into our next question very well. You received a refund request for some diagnostic tests, but the patient was outpatient at the time. Okay, that's great. But remember I talked about that 3-day or 1-day payment window in which it actually goes back before the start of the inpatient care for 3 days or 1 day, depending on the type of facility, whether they are wholly owned or wholly operated by a hospital, then they become part of the admission service. This is exactly what we're talking about. You may not even be aware that it's happening until after it happens. You did everything, you checked, you're even looking today and it says they're outpatient, but you look and it says, oh, the inpatient started 2 days from today. Odds are if that's an acute care hospital, we're going to look at that 3-day bundling and that's what's happening there. We're taking it back into that payment window, that bundling concept then applies. Now, again, I can't say for sure because I don't have a claim number and I don't have all of that additional information. You would have to call customer service with the claim number and have them directly check that claim number or any other information you have. Another question that was asked related to this, and this is why we put check eligibility, is does hospital bundling always apply? The answer is no. And I simply stated this right away. What if the patient doesn't have Medicare Part A? They don't have Medicare Part A. Guess what? Hospital bundling doesn't apply because they don't have Medicare Part A coverage. However, Medicare Part A also has a limited number of days. So let's talk about a hospital stay. Medicare covers 90 inpatient days per benefit period. That means Medicare pays for 90 inpatient medically necessary days until there is an additional 60-day break before any other covered days. That's a benefit period. So a benefit period can be much longer than 90 days. much longer than 90 days. Patients could have one benefit period their entire life if they never have a 60-day lapse of medically necessary inpatient care. Or they could have a 5-day benefit period because they have a 60-day lapse and they're not admitted till 70 days later. That would then start a new benefit period. So it's a little bit different than the Part B concepts, than the Part B services. With that said, patients also do have, again, for hospitals, 90 covered days, but they have this special election. It's called lifetime reserve days. This gives them 60 additional days. The difference is the 90 days renew after a 60-day lapse in inpatient care. The additional 60 days do not. The additional 60 days will cost the patient more money. So if the patient remains in the hospital for any reason, but is not in a medically necessary stay, that could cause the start of the care in between. Also, if the patient is outpatient for more, then yes, this bundling concept may go away. But more importantly, if they don't have Part A at all, it's never going to be in effect. So again, please verify that patient status. Check there always. Please use the term, are you staying somewhere else? Are you in a facility? Something like that. Are you visiting a facility? We do want to make sure that you're aware of the terminology to use. That's just important because some patients don't necessarily think of that facility, even a skilled nursing facility, as their own home. Okay. All right, so the next type of bundling that we want to talk about is skilled nursing facility consolidated billing. Now, again, this is bundling, but this one is very specific. And what it does is it looks at procedure codes that the SNF, the skilled nursing facility, should be able to perform, and then provides exceptions as to whether or not you can bill separately for them. Now, keep in mind, there are some procedure codes that are in certain places. So if you have it in a hospital, it would be separately billable. But if you have it in an ambulatory surgery center, it would be included. Also, if you had it in a freestanding diagnostic center, it would be included. Now, surgeries are, again, unique in that there are only a limited number of surgeries that can actually be performed in a skilled nursing facility safely versus many that cannot. So CMS actually has a list just for that purpose. So when we talk about skilled nursing facilities, there's also one other thing that has to apply before the bundling concept can apply. First, is it medically necessary stay, or are they living there in a nursing facility? Though they may have skilled beds, are they not in that? If it's not medically necessary, then Medicare does not apply the concept. Okay. Did they have what is called a 3-day qualifying stay, which means that Medicare will then be covering the stay. 3-day qualifying stays are in a hospital. They must be in for 3 paid days. Admission is day 1, or I'm sorry, then the next day would be day 2, the next day would be day 3. The discharge day does not count as a day. The discharge day does not count. So some people like to say 3 midnight census stays. That works too. However you want to do that, but it has to be the 3, which is technically 4 calendar days because, again, that discharge day doesn't count. So 3 qualifying stays. If it doesn't meet that criteria, then Medicare also will not pay for it. We will also look for that qualifying stay to have been within 30 days normally. If there's a special circumstance, we'll talk about that, but that's something that you have to do an appeal to tell us there's a special circumstance. What's going on? Why would you do that? Okay. Also, when we look at consolidated billing to see whether it applies, we look to see if the skilled nursing facility has discharged the patient or has them on a leave of absence. Some people will go on a leave of absence to see if they can medically sustain at home, to see if this is going to be medically necessary, to test their skills as they begin to advance, depending on the conditions that they have. And it may be for a day or 2 where they're actually going to spend those nights at home. During that time, should something happen, consolidated billing doesn't apply because the SNF is not receiving payment for it. But it's dependent upon the skilled nursing facility billing us for that correctly. Okay, they have to bill us for the leave of absence in the system. And until that bill comes in to say, hey, these are my leave of absence days, we will continue to apply it, the inpatient bundling concept for skilled nursing facilities. So you can see there's lots of caveats that go back and forth. The question I was asking, I've already wanted to make sure that I did cover this, is what is this 3-day qualifying stay for a skilled nursing facility? Again, look at that midnights. So you're going to count day 1 is admission, day 2 is the second day 3 is the third day 4 is the day of discharge. That does not count. So 3 qualifying days. And again, please follow that 30-day criteria. In most cases, this is what's going to be required. Now, there may be a situation where it was planned or there was a lapse of time or something in between, but we would need to know that. The next question again comes back to that 3-day qualifying stay. And the question that was asked is, does observation care count towards a 3-day qualifying stay? Think back to when I talked about inpatient care and I talked about observation care and I said, nope, doesn't count. Observation care is always outpatient, not inpatient. Therefore, it doesn't count. Okay. So what do you have to do? Well, start with looking at the skilled nursing facility and saying, hey, is this a medically necessary stay? And are they within their 100 Medicare covered days? So yes, it's medically necessary. Yes, they're within their 100 covered days. Okay. Or is Medicare covering the stay at all? Or are you building this with Medicare saying don't cover the stay because it doesn't meet the qualifying criteria, such as not having a 3-day qualifying stay? And are you billing a leave of absence for my day? So this is the day they came to see us. Are you leave of absencing them for that day? If you are, then it's billed separately. So lots of questions can go back and forth on that. And it's not quite as easy as just looking up a code and saying yes or no. I know a lot of people make it seem like that, but it's not quite that easy. With this, I do want to stop for a second and I do want to show you an area on the CMS website because the next question related to that is about finding the resources for it. So it's cms.gov. This is the provider website. If you go to Medicare and you go to coding and billing, we're talking about skilled nursing facility consolidated billing. So we're going to go to coding and billing. Then we're going to look at all these different files. We're going to look to the one on the right side and we're going to say skilled nursing facility consolidated billing. This is the actual website you'll need to use to determine procedure by procedure. There are 2 sets of files, and the first one is your Part B MAC updates, and your second one is your Part A. The Part A MAC updates are going to be the most commonly used one if they're in a medically necessary inpatient stay. Again, the Part A MAC updates. This says that they have to be billed to the SNF. The Part B one does give you updates, but it's things like, hey, there's a professional service. So does that professional service then meet a separately billable service? Oh, okay. Or we're doing a diagnostic or a radiological service. Any of those, do I need to separately bill them? So yep, they're on the Part A file, but we look at the Part B file and it says, hold up, you need to bill a technical professional component. Also, there's one specific to ambulance services that says if it's not part of, bundled into another service, in other words, the ambulance transports to a hospital to have an MRI and then back to the skilled nursing facility, that ambulance service is actually part of the MRI. It's not a separately payable run because it's part of the MRI. You can't do the MRI without getting them there, part of. Now, if it's to an ER, then we're looking at it in a completely different perspective because the ambulance run to the ER is not part of the ER, and that's a way that CMS defines it. And that would also be then on the Part B MAC updates versus the Part A MAC updates. It gets very confusing. We do teach a class on that, so I don't want you guys to get hung up and be like, got it all. You're not going to get it all with that simple explanation. And the last one, we'll talk about therapy services, which is outpatient rehabilitation therapy services that always must be billed. So you can go through those different updates and take a look at that. Hopefully that gives you a base resource. I will tell you that we are teaching courses on this because there's a lot more that goes into it. And because it is such a complex topic, I don't think I would have time to get through all of it today. Home health is another form of bundling. And so again, you must determine first, is there a home health plan of care or a home health agency involved? Medicare will cover home services and you can bill with a patient's home for certain things, and that is fine. However, once there's a home health plan of care in which an elected home health agency is involved, that's when home health gets involved, and that's when the agency is responsible. So that's when bundling actually gets billed to them. So we have to look at our portal and check the eligibility section for home health and check and see if there's something within that episode of care in that home health agency. If there is, then you're going to be billing the home health agency, and if there's not, then you will bill Medicare directly. Also, hospice. Now, this again is one that is a little confusing for some people, so we do want to talk a little bit about hospice. So first of all, it has to be the diagnosis related to the hospice. If it's not, and it's an unrelated service, you do need to bill that accordingly. Now, the diagnosis is not just the hospice diagnosis. It can be within the family of diagnosis, so that's where it gets a little bit confusing. What the patient does is elects hospice care and an individual provider to do non-medical care for that condition. That's what the hospice care is. It's comfort care, or a variety of other terms used for it. They can discharge themselves or remove themselves from hospice at any given point. Hospice begins on the date of election after the admission is complete. So you could have services before or after a hospice. What do you do and how do you do this? First, verify within our system, within our portal, whether or not they have a hospice on file for that date of service. Let's say that they do, and it's going to be related to that diagnosis. Now, you are a professional or supplier billing on a CMS 1500 or an 837P. Now you get to pick one of two modifiers, and they're actually listed on the bottom of this slide. So it's not related. If it's related to the hospice, bill the hospice. If it's related to that diagnosis in any way, bill the hospice. If it is not related, then you want to bill the GW or the GV. GV is only for the attending physician who is under arrangement for the hospice care provider. So basically, you're not employed, you're not paid under arrangement, but you are the elected hospice provider managing that hospice care. You can be paid separately, and that's what the GV modifier. But again, you have to meet all of those criteria. It's not just for any physician, it's only for the attending. Very limited circumstances where that would be used. The GW, on the other hand, is for everything else, billed on those two types of claims. So it could be used on an ambulance run, it could be used on a physician service, it could be used on a diagnostic test, it could be used on a variety of other things. Basically, this is not related to hospice. Put a GW on it to tell us that. Now, I did mention that there is a UB04 or 837I. Here you need to make sure that you have the correct condition codes on there. D1 is an adjustment for a condition code that doesn't apply, so there's no covered charge. We should reject the claim for home health, hospice, or HMO and other overlap reasons that have been updated. Sometimes that happens, right? We take money back, but you need to do a claim to say, hey, keep this in there, keep tracking the benefit period, keep doing this, only we don't expect to get paid because it should go to the hospice to be paid, because it should go to. That's one that you would want to use. 07, treatment of a non-terminal condition for a hospice patient. Did you guys catch that? Non-terminal, not related to the hospice condition. So if the patient has elected hospice care, but the provider is not treating that elected condition, I need those to be billed with a 07. If no 07 on the claim, we're going to assume, based on the information you coded to us, it's related. 52, hospice beneficiary moves out of the service area. In other words, I've elected a hospice, but I'm no longer in that service area, then guess what? We can't expect that hospice to pay because they can't see you, so you want to make sure that you're putting the condition code 52 on there. So hopefully all of those make sense. Again, the coding specific to that is different, and it does really depend on what you're billing there. So I want to make sure that you're aware. I'm sorry, not what you're billing, but how you're billing. Hopefully that did answer those questions related to that. The question was basically just a basic billing question, so I didn't know if you were which portion you were billing. So if you have more, please ask that. All right, demonstrations. This one was causing a lot of confusion for people because I think because they're so unique. And so first, go on the CMS website, look for the demonstration project. You have to verify whether or not it even falls into the demonstration project. If it does, each demonstration project will have certain billing instructions, whether or not it's billed to certain people, whether it's reviewed in a certain manner. There's a variety of different things. So bill whoever the designated payer is for that project. It may be your MAC, it may not be your MAC, but also follow the specific guidelines for that demonstration project. I think the person that was asking about this was asking about a demonstration project, and from what I could tell, that one is very specific to ambulance, and it's very specific to a geographical area, and it is a ambulance that elected to be within this program, and so they are then being able to bill for certain codes, coding like treat, no transport, other things like that. Those are then billed to the MAC, but they have to be billed with a certain modifier according to the demonstration project information for that area. So it gets really complex, and that's just one example of the complexity that can actually be there. So demonstration projects, lots going on with that. We'll get more into those if you're looking at that. Again, on this particular section, if you say, hey, is there one CMS website area that lists the demonstration projects? The answer is no, there's not. The initiatives can be something, you'll find some of them here, just depending on what type it is, and under innovation centers. So it just really depends, some different innovation models. So it could be here. A data model is another one that can be here. It just depends on what you're looking for. The easiest way that I think to find these is to look at this one and to kind of look around a little bit. Here is the one that I was talking about with ambulance. Okay, I'm like, it's not working. So this one, you can see they have a variety of different pieces of ambulance. Ambulance services center is where I like to go. When I scroll down, it'll talk about pricing, public files, all those different things. See this data collection item right here? This is one of the ambulance ones that's going on right now. No, this is not specific to billing. Instead, each ambulance provider is being asked to report certain data. The data is then being used to analysis to adjust the ambulance fee schedule. So that's why I chose this one, because it's kind of in a weird location. You can see all the collection instruments and all these different things going on, but it's not necessarily in a set section. And that's where some people get confused. I think they're saying, hey, what's this research, or what's this resource, or what's this? And unfortunately, it just doesn't happen that way with some of the demonstration projects. Again, so they can be in the Medicare area, they can be under initiatives. It's just not going to be super clear to you. So I apologize for the person that asked that question. I don't have a better answer for you. Sometimes it's best to Google them and see if you can find them on Google. Again, any search engine will work for that. So just a lot that goes on with that. So let's see. So we're in the question and answer section, so you guys can add any questions that you do have. One of the areas that I was asked for is with this one, as I'm going to show you, but I'll mention it real quick, is there an area in direct data entry that shows certain pieces and items, and I'm not sure what the pieces and items you're looking for are. There was no specific item or information. So here's what I like to do for direct data entry, just myself. If I'm going out here, I do come to our website, WPS.jha. I like to start with a DDE overview, and Aline might do this quite differently than I do. I just like it because it comes up super quick. I can come there. Oh, let me get into a Part A section. Direct data entry is a system that enters into the UB04 837I system. It allows you to access the system, which is then all explained here. Okay, but way down here on the bottom, the last item is the DDE manual. I'm not going to download the manual and open up, but it'll walk you through all the different screens, all the information that we need on that. So if you have anything input from there, let me know. If you have more questions or want more information on that, let me know. Aline, any questions in the chat?
We don't have any questions that you haven't addressed.
Okay, perfect. One other item I'd like to show you guys just before we move on. If you come into Medicare, regulations and guidance, and you go into the manuals area, please take a look at the different manuals and be aware of what is here, because all of these different manuals do contain a variety of pieces of information. The reason that I'm bringing this up is because the demonstration projects, it talks in general about what a demonstration project is in this manual, but it does not list the actual demonstration projects in the manual. And I forgot to address that portion. This is the demonstrations area. And you can see it does have its own publication. It's 100-19. And then you go through and it talks about all the information you might need to know But you're like, none of it makes any sense. Well, that's because these are all the different demonstrations. So you can see CMS, might have one or two as we're hitting page 7 of the demonstrations. And then it tells you, what do you need to know about those? But it actually takes you to the information. So if you're looking for something like that, that might be helpful to you as well. I did forget to add that in, so I thought I would quickly throw that in before I moved on to the next section. Aline, sorry, did anything come in while I was talking?
Yes, actually, we did get a question from Ashley. Do you have to be contracted with the hospice or home health agency in order to bill them?
Great question. And no, you don't. CMS, as part of their conditions of payment, say that they are responsible for paying those types of services. The way that the contract plays into that is that if you have a contract and you have an established rate with them in that contract, that is legal and binding. But if you don't, then no, you still have to bill them and they still do have to pay you.
No additional questions at this time.
All right. Oops, sorry. So the next section is just where you're going to find some help. Now, I've shown you a couple of different things. So I will run through a variety of different ones. The first one is the portal, and I think this is going to be one that we do want to talk a little bit about. And so I'm going to jump back to the website and we're going to look at it. The website that we want to go to is our website, and that is WPSGHA.com. Doesn't matter where you're at, but you can see right up on, let me make this a little bigger here for you. On the right side, it'll say Portal User Manual. It's right underneath the user ID and password. Now, unfortunately, I can't log into this because it's got PHI and PII, and I'm not allowed to display that. So I got to use the Portal User Manual. A lot of what we're going to be looking for in this case is under eligibility. So I'm going to scroll down, look away if you don't like a fast scroll, but I'll just warn you, look away. But okay, if I scroll down, you come to these transactions here and you have patient and eligibility. Eligibility transaction contains a lot of what we're talking about here. So if we go down, it's going to tell you how to do the actual eligibility search, but then it's going to be the Part A deductible information, has some information. Home health is here. Additional coverage would be here, MA plans, hospice, all of these different things are important to understand. And this is what we're really looking at. I'm going to jump just as an example to the Part A deductible. So if I keep scrolling down, it'll tell you what all the information is, and it'll highlight and say, this is your summary. But if we go to the Part A deductible, it'll say coverage time, Part A deductible base, Part A deductible remaining. Remember, the base is the total, the deductible remaining is what is remaining per benefit period. So without that 60-day lapse, this is not a yearly deductible. And that's one of the things I wanted to emphasize. This is a benefit period deductible. So you do have to have that 60 days. Hospital spell dates, again, earliest billing remaining, all of those, that's the same thing. Inpatient and copayment days remaining. So when we look at this one, the first so many days are deductible applied, and then after that they're paid, and then we hit copayment days. And Alina, correct me, but I think it's 60 and 30. I'm just drawing a blank on that.
You're fine. You're correct.
Okay. So when we look at the hospital, that's what it's talking about. Is it the first 60 deductible days that then go to 100% once deductibles met? And then after that, you reach day 61, and then you got 30 days of that 90-day period, which are copay days. And then you reach day 91, where if they elect to use those lifetime reserve days, we got a different set of copayment days. That's what it's talking about with all of these different factors in there. But then you're going to hit down here, and here's the same thing for skilled nursing facility. Please remember that skilled nursing facility offers 100 days and it's 2080. So hopefully that makes sense for everybody. If not, let me know and I'll put that back in there. But that's one of the big ones that I do happen to like. I do like to scroll through this if you have more information or you're looking for specific pieces of information, such as home health, and you want to know which home health do I bill. You do have to come out, and it does take a little bit of work, but if we scroll down, D therapy. Again, look away as I scroll quickly through this, right? QMB, here's secondary payer. Home health, here we go. It'll say, okay, here's when your home health period started and ended. Now, if you don't have an end date, that means it's active. It's an active home health period. The date of earliest and latest billing activity from the home health providers, NPI, contact number and name, patient status, indicating the beneficiary is actively receiving services. and then the notice of admission indicator. But the key thing a lot of people like is this right here. It's not there for every particular one, but it is there for this. I'm going to scroll down again, and you can see here again, we've got the hospice. Unfortunately, we don't give you quite as much information on the hospice one. We do give you their MPI, and you will have to look that up on your own. But it does give you a variety of pieces of information to help you out. Now you say, why doesn't it give me the same information, or why can't I get as much? Look, I can only give you what CMS gives me, and that's what they give me in their eligibility file. So therefore that's what you get. So hopefully that makes sense to everybody, and that is our portal. Okay. Portal. SNF Consolidated Billing article. This is on our website. It is a resource. It's going to explain the same thing, but what's nice about this is it's a Part A resource. So it's going to talk about the Part A files and how to use them. It actually will provide the same as the Part A reference guide, which is available on the CMS website, and talks about how to use them. Some people just find this easier. It's really just an extra resource in case you find it easier. All right. Overlap. This talks about all the different types of overlaps that occur. Now, a lot of people say, why didn't I include inpatient psychiatric hospital? Well, that's because it's a hospital. Long-term care, hospital. Again, hospital. So these are all the different ways and the methodologies in which a hospital can be paid. So outpatient services, critical access hospital, again, they're just different payment methodologies. We did talk about skilled nursing, home health, hospice, rehab facilities, or comprehensive outpatient rehab facilities, and then those two, and then end-stage renal disease facilities. And so these are just all types of bundlings that occur. Again, same concept though. If you have a comprehensive outpatient rehab facility and it's something related to that type of service, what types of services are they expected to provide? Rehabilitation services such as physical therapy, occupational therapy, speech language pathology. But if you want to learn more about that, we do recommend taking a look and just kind of looking at this. It'll help you through those different processes. Modifiers is always a big question for us. So I put this one in. It's just a modifier, a bunch of modifier fact sheets that are designed to help you. So again, you can take a look at any of the different modifiers that we do offer. If you have additional information, let us know. We can actually, take a look a little bit more on that. The next slide is based on the procedure to procedure edits from CMS, which is part of the National Correct Coding Initiative edits. The procedure to procedure edits are two codes that are not separately payable when billed together for the same provider for the same data service for the same patients. There are some that allow a modifier. The question related to this is they're not familiar with the procedure to procedure edits. So I think what we need to do is just quickly show you that they are part of CMS's National Correct Coding Initiative. So again, CMS website, let's jump back for 1 second here. On there, you're going to come back down and you're going to go to Coding and Billing, National Correct Coding Initiative, and you're going to look down this side because CMS does have 3 different types: medically unlikely edits, add-on code edits, and procedure to procedure edits. These are all part of the National Correct Coding Initiative, which is why they're in this section. In particular, it's the procedure to procedure. You have 2 different types of edits: practitioner edits. These are your these are your 1500 837P. Hospital edits. These are your UB 04 837Is. And you need to tell me which kind you're looking at because I don't have that information. So hopefully I got enough information there to help you. I did receive a question on bundling, and I'm going to move to the next slide with this one. This is a type of bundling that is actually done. Sorry, don't know what I did there. Type of bundling that is, the next slide is actually a sample of the edit. So you can see here's the payable code, and then the not payable code, the bundled code, edit dates, whether a modifier is allowed, and the misuse. So column 1 and 2, this is the rationale for it. So it's mutually exclusive. If it has a termination date, then that one's already done. If it doesn't, then that one's still in effect. And you can see, okay, here's just, again, this is where the CPT came in, but here's a 99215 with a G027. This one is expired. Okay, so we go to 271. This one's not expired. It's still active. Physician fee schedule bundled. This is a type of bundling that is not related to another provider, so it's not something you'll be billing to another provider. It's on a physician service or a professional charge, and on their fee schedule, we have a B as a status, which means it's bundled. That's all you got. So it's not billable. It doesn't matter if you even perform. This is the only service you've ever done. ever done, it's still going to be a bundled service. So that's what we're talking about there. My sample for that is on the next slide, and you can see it right here with this 99295. Gives a little definition, but you can see the B. You can see those B statuses. This means it doesn't matter what else you've done that day, we're never going to pay you. This is going to be part of some other magic service. So some of those could be part of something like putting it in. So stitches, you put the stitches in, you got to take them out. We don't pay separately for that removal. On the other hand, we do say, hey, it's part of the total fee for putting the stitches in. So please make sure that you're doing that. If you do, you got to bundle it. Well, how do we bundle it? We bundle it into whoever the provider was that put them in, regardless of whether or not that's you. So that's kind of what we were looking at there. So hopefully that gives a pretty good explanation and does answer your question on that. I don't have any other questions. So Aline, do we have any questions?
We do not have any additional questions at this time.
Okay, let's keep going then. So as I promised you, I will send, the system will send you, I don't personally send it out, not me. The system's going to send you a certificate of achievement unless you dialed in. If you dialed in, I don't have your email, then you're going to have to email us. We'll talk about that in just a moment. But the certificate of achievement contains two things. First, it is going to contain a survey link, and you can take that survey. It's also going to contain your contact hours. We do not offer CEUs. It's up to a governing body to offer those. Here's what we do offer: a certificate in this email, which you can download, save, PDF, whatever you want to do, and then you're responsible for getting it to the governing body to get the CEUs. We do offer contact hours. This course is worth 1 contact hour. As I said, if you have questions or if you need that certificate, please email us. Now, again, certificates are only available for those who dialed in. If you did not dial in, I'm going to verify that. Here's what I need you to do. 1, if you dialed in, you have to tell me you dialed in. 2, I have to have a phone number. If I can't verify your phone number, I can't do anything with that. I have to have a verifiable phone number. If I can verify the phone number and that you were on, then we can send you a different form of a certificate. But it's the same one that you've already gotten online if you've already got it. So please do include today's topic. That's billing another provider. However you want to do that, that would be great. Please make sure it's in the subject line so it comes to me. You get 7 days, y'all, to get that done. All right. That all-important survey is next. So again, I'm just going to ask you guys to take this survey. I'm going to have Aline put a link in it. I've already shown you that you're going to get it in an email. I'm even going to think it's so important. I'm going to give you a pop-up box that's going to look like the bottom one on here. It's got a little orange triangle, and then I've got the highlighted information. Please take the opportunity to give me your good, your bad, and your ugly. What did I do well? What could I improve on? Did you like the PowerPoint and the resources that I showed you? Were there other things I could have done better? All right. That brings us to the end. Thanks for listening. Thanks for attending. We encourage you to provide feedback on the survey. Also, remember, we encourage you to provide additional topics. Really important that we get those topics so we can help to get you what you need. Remember to rate WPS as an overall and on the survey. Please take time to review our live events page to register for any additional courses, to register for different things you might want. Also, look at the Encore page for topics that might be there. If not, check out the Encore playlist on our YouTube channel. On behalf of myself, Aline, all of Provider Outreach Education, thanks for participating. We look forward to your survey comments, and we hope you'll join us in the future for education. You may now disconnect.